But I want to say welcome to our Connect to Healthy Living event. Dr. Snodgrass, who is our program director for sports medicine, cannot make it tonight due to a little emergency, but we still have our two amazing surgeons, Dr. Amadi and Dr. Ramkumar. So Dr. Amadi specializes in shoulder and elbow injuries, and Dr. Ramkumar is hip and knee conditions. They are both local, and they are two amazing surgeons we have on our staff. And I just want to say thank you to them for taking the time to join us tonight to give you all some great knowledge. There'll be plenty of time for questions at the end. So there is a note section on the back of your sheet where you can jot them down. And we hope to answer all your questions. Dr. Ramkumar?
Thanks to MemorialCare and thanks to everyone for coming and taking the time out of your busy schedules to hear me talk about the hip. I'm really passionate about the hip, and but I also take care of both hips and knees. So I'm going to try to help you rethink what we understand about the hip, because a lot has changed in the last Got it. Is that better? Okay. So a lot has changed about the hip over the last 10 to 15 years. And it's important that here in Seal Beach, we actually know what has changed because it can help us better understand how we treat it. So first and foremost, what is hip preservation? Hip preservation is essentially the treatment of people who have hip issues but don't have arthritis. And it's a new field with a lot of new evidence. Additionally, it can be separated into two different categories, impingement and instability. Impingement generally means you have too much constraint. Historically, people would say, my hips feel stiff, they feel tight, I don't have as much motion. It doesn't really bother me. Sometimes it's a little bit of a toothache. Instability are people who are very thin and have almost too much motion, but then they feel fatigued in their legs and they just can't really do too much. And so it's our job to help understand which of those two patients someone is. Additionally, it's affected by a lot more than we actually really understand. How someone walks can tell you a lot about someone's hips. For example, LeBron James, you've all seen the way his feet point outwards. I can tell from that he has very large bony impingement, he has retroverted femurs, and he's a setup for arthritis just based off of his gait. And we've learned a lot more for that. Similarly, that doesn't necessarily mean other people who aren't walking that way have that issue too. For example, Michael Jordan, his feet always point inwards, and he has different kinds of hip pathology that will be a setup downstream. So together, we're really understanding what exactly hip issues are, and they really are the core feature that drive a lot of issues in the lower extremities, and they're easily overlooked. But let's talk about what the anatomy is first, just to give everyone a basic foundation. So first, there is a femoral neck, and it has a growth plate. So as a child, you actually grow through that neck, and you can see it on that chart. Second, there's an acetabular rim, which is the socket, and that also has a location of where the quadriceps tendon inserts. Third is the labrum, which everyone gets really excited about because they say they have a labrum tear and we should run in and go and fix it, when in reality the labrum is important only from our standpoint because it's the only thing in your hip that's telling you that you're in pain and there's a problem with it. Finally, there's cartilage, which doesn't have pain receptors. So you can injure the cartilage and not even know it. Only when you injure the cartilage and then injure the labrum, then do you have pain issues. Finally, super important, the hip is surrounded and attached by 17 different muscles. So if you feel sore, weak, it is incumbent on the hip expert to first rule out a central core issue of what's going on with the hip before we point to SI joint pain or muscular dysfunction, because no hip can do well with a core issue underlying that's problematic. And so, of course, if you have a bad hip, you're going to have any of those 17 muscles be problematic. So what is hip impingement? Hip impingement is called several things. It's called FAI, also known as the head, acetabular, the socket, impingement. That is the most common cause of non-arthritic hip pain. Additionally, it's like we mentioned earlier, it can be pain in the groin, pain in the thigh, or pain rarely, but sometimes still in the buttock. Oftentimes, it comes with low back pain. Patients who are under 35 years old and have hip issues, low back pain is the first thing that these patients will complain of, and on average, it takes about 3 to 4 doctors for them to finally see me and diagnose them with hip impingement. So it's a very confusing picture for many patients, and it's very rough because by the time they get to me, I have to undo a lot of the things that they've been told in this very nebulous joint that makes things very confusing because it's close to the pelvis, it's close to the spine, it's close to the knee, and it's a very confusing thing for patients. Many people call it a pulled muscle. They call it piriformis syndrome. They call it SI joint pain. That's not a real diagnosis. That's describing some of the things that the hip is aching over. Most commonly, people who have hip impingement or hip pain, they have pain with sitting. They have pain with getting out of their chair, pain with driving in a car for a long time. A lot of people who drive a lot in long traffic, it's very difficult for them to get out of a low bucket seat. That's why you'll see some people will gravitate towards the bar stool seating at restaurants because it doesn't make them sit as deep as they need to or squat as much as they need to. So pain with squatting and lunging. But importantly, and the reason I'm passionate about it, is that it's very common. It is very poorly recognized, especially in Southern California. It's easily misunderstood, and it's an incredible story that I want to share with you. So, taking a better look at this figure, you will see a close-up of the hip. You can see the head, and it has a growth plate. We're often taught in residency and medical school, all our education, that when the growth plate has a severe injury, an obvious injury, that is known as a slipped capital femoral epiphysis, where you can see in the bottom right, like the head falls off the neck. I hope you can all appreciate that in the bottom right image. But that is a very dramatic presentation of someone who needs help. But it's not that binary. It's not black and white. There are injuries that happen to the growth plate in a continuum. And when it happens between the stable, normal hip and the unstable hip, that's where hip impingement lives, and that's the source of all these issues and why that can happen. So specifically looking at this video, here you have extra bone from a growth plate injury, and when you're standing, everything is fine. But when you get into a low seat or any squatting position, that bone first preferentially engages the cartilage. The cartilage, like I just told you, has no pain receptors, so it doesn't know you're in pain. And then when the cartilage gets injured enough, then it tears the labrum. The labrum does have pain receptors, and that's typically when people come and see me. And then their MRI may or may not show that there's a tear of the labrum. Unfortunately, a lot of the imaging centers that we get our imaging from, they misdiagnose or inappropriately diagnosed normal labrum pathology because it's difficult to actually appreciate 75% of the time. So first the cartilage gets injured, then the labrum gets injured. The cartilage doesn't have pain receptors, the labrum does. And by the time someone has gotten to see me, it's almost 6 months to a year to 5 years to 10 years, okay? On the top left is what a normal hip looks like. On the bottom left is that bump called a cam lesion, which we just showed you. Another rendition of areas where there's extra bone is called pincer on the top right. Why does bone deposit there? I just explained to you that the reason there's growth plate injury, that there's an additional bump, is because of the growth plate injury, correct? I didn't explain what happens on the acetabular side. Well, there's the biggest muscle in your body called, or the second biggest, called the quadriceps tendon, which attaches just on that rim. And just like when you have a tendonitis and you're growing, extra bone gets deposited on that rim, and it can cause additional impingement over there. And 85% of patients with impingement have a combination of both. So how does someone, if you were to imagine, have this abnormal bone happening on both sides? It's pretty obvious. You have to be a pretty active individual, right? People who are running and jumping as an adolescent, as a young adult, that's the only way how you load your growth plate, how you load your quad tendons, and you're just very active. So that is the history and the story of how an injured, ailing, aching hip comes to be. So which of these 3 patients would you say have FAI? Anyone can shout out. It's a trick question because it's all the same patient, okay? So the patient x-ray on the left, this is a professional athlete, comes to the ER with that x-ray. The ER says, there's no fracture, there's nothing I can see, gets a CAT scan, totally normal, everything's fine. They come to my clinic because their pain still isn't much better, but it's still a little bit better, 6 months to a year later, and then I ask for this special view in the middle. That special view in the middle shows an obvious bump. If you look at the femoral head, you can tell where on the left side of the neck it goes from sphere to neck. But on the right side, you can see a giant bump. After surgery on the right side is with the bump gone. So on the right side is a perfectly normal hip after surgery. In the middle is that giant bump that I showed you in the 3-dimensional imaging. So you cannot have that bump in there because that's killing the cartilage and it's also killing the labrum. So it's all 3 patients, and you can easily see how this is easily missed, and this becomes a very problematic process of finding the correct doctor to actually take care of this situation. Secondly, what do these 2 things have in common? I kind of hinted at it, but this is a knee x-ray on the left where you have a patellar tendon that's being overused in a professional basketball player. And when that happens, when you overuse a tendon, it creates and leaves bone at the tubercle. And that's the same thing that's happening on the shoulder that Dr. Ahmadi is going to talk to you about on the right, which when you have a tendon that's being overused, it lays down bone. So excessive use of a tendon lays down bone. And like I just explained to you with this pathology called pincer, that quadriceps tendon, which inserts on there, causes that extra bone, and then when you get back into that sitting position, guess what happens? That extra bone and labrum contact the femur, and that's called hip impingement. This is a CAT scan rendition of the pathology. Everything in red is abnormal, incorrect bone that's causing pain and disability. Now, it all comes down to when in the life of a patient I see them. And so if this patient doesn't see me for 45 years after their growth plates have already closed, and they're 20 years old, 45 years later, they're 65, 70, they certainly have arthritis because they've let it go on that long enough. Because as I just explained, the first thing that problem does is it kills the painless cartilage, which can't tell you that there's a problem. And then maybe that problem got dulled when you tore the labrum as well. And you have this bony issue going in your body for your entire life, and you just have essentially been ignoring it. So depends on when patients see me and depends on what their imaging looks like. This is scope photos or photos from surgery on the left side is when you get into a hip, everything that's red, it should not be red. That means it's in pain, it's inflamed, and it's problematic. After clearing some of the debris on the right side, you'll see the pincer lesion, what my instrument is next to. That's abnormal bone that is contacting the hip prematurely. That's called rim lesion. You can tell the labrum, it should be all white, and it's red, purplish, getting squished with all those activities. So hip stiffness, for your guys' takeaway, hip stiffness is never normal. If you have a child, grandchild, whoever, if they feel like their hips are tight, that's not normal, okay? Secondly, it causes poor athletic performance. It causes poor day-to-day performance. You can't sit, you can't squat, you can't lunge. These patients are constantly stretching with temporary relief. And by the way, when you have stiffness, it causes downstream effects. Patients with undiagnosed hip impingement, even if it hasn't reached the labrum and causing pain, 4 times higher risk of tearing your ACL because you're relying on the knee to land after a sport or activity, which is a huge problem, obviously. Also, these patients have a 2 times higher risk of having a lumbar disc herniation because guess what? If your hip isn't moving properly, your spine's going to try to accommodate. Does that make sense? So not having normal rotational motion of what the hip is supposed to give you causes downstream effects at adjacent joints, the spine and the knee. This is also the most common cause of arthritis, obviously, because of all the things we just talked about. It is reversible if you're caught at the right stage. This is how you can recognize a hip impingement. One, it just starts with talking to a patient. Two, it knows you're at-risk sports. Hockey has a 90% incidence if you are an adolescent playing hockey up until your young adulthood. 90% of patients have radiographic signs of hip impingement. Lacrosse has a 90% incidence. Softball has a near 100% incidence at 98%. Track and field is about 70%. Volleyball is about 60%. And baseball, if you're a catcher, it's almost 100%. But if you're a pitcher, it's probably about 70%. It's highly dependent on what position you're putting your body in. A physical exam is key. Those unique x-ray views in my office is what also helps clinch that diagnosis. Everyone gets excited about an MRI. I don't care about the MRI. You can tell it on x-rays. And most of the time, people who get an MRI, some radiologists will say, I don't see a labral tear, and then they'll never get to see me in the first place. Or people that do what I do also. Sometimes an injection can be helpful to prove that the pathology is coming from the hip. That, as you can understand, the hip impingement is a bony problem, and the only thing that we have to look at abnormal and normal bone is a CAT scan, so that's super important. And then early triage to a hip specialist is super important. So signs of hip impingement, these are people who, we already talked about. They're sore, tight, stiff, uncomfortable. They're holding their pelvis in that C-shaped sign like shown in the image. Long car rides are very bothersome, all the stuff that we already talked about. So deep flexion, resisted straight leg raise, all these certain exam maneuvers that we do that prove that that's a diagnosis. So hip arthroscopy is a very interesting story also. It was once poorly indicated, meaning we didn't know who we should do the surgery on. We didn't really understand the diagnosis, and it was poorly taught 20 years ago. I trained with the guy that did it for the first time in the history of America, bringing this operation in New York, and you know what they would do? They would go in, look inside the hip, remove the labrum because that's the cause of pain, and not do anything about the abnormal bone. Obviously, that's, as you guys all understand from what we discussed, that's the wrong thing to do. And depending on when you trained, going in and just doing that clean-out procedure, it's not helping anyone, and in fact, it's making it worse. So hip arthroscopy got a really bad reputation for the last, I bet you can talk to many orthopedic surgeons today who will say it's a bad operation. But you have to be careful about which patients would benefit from it. You have to talk to them about the specific things that we're trying to achieve, and you have to do it in a very technical manner. And so it was once poorly executed. Now it's better understood and well executed. Now the success rate for patients who are appropriately seen by a hip specialist is up to 95 to 98% success rate. And we found that if you get to these patients at the right time, it delays the chance of them having arthritis 25% of the time. So that's a huge thing. Some people would say it is one of the most technically difficult operations in elective orthopedics. Some people might differ on that, but it's not like a knee and it's not like a shoulder. It's just a very different operation. It's, as the person that taught me this operation, he said it's the only operation in orthopedics that gives patients more range of motion than beforehand. It requires more physical therapy maintenance. Like the next day, they are on the stationary bike. I had two patients I did bilateral, both hips at the same time, and their expectation was you need to bike 40 miles in the first week after surgery, and they both did that. And that's how you take care of these hips. It's just different than doing knees and shoulders. And so recovery, like I talked about, you're on the stationary bike the next day. You're wearing a brace. You're driving by 2 weeks. Your goal is to have a normal gait by 4 weeks. And you're returning to sport by 3 months. So this is an example on the left of what an abnormal bump looks like. And then when you shave down, when you show the bump is in the middle photo, that's all pathologic or bad abnormal bone. And then after the surgery on the right is what a normal shaved down, normal contoured hip should look like. Bottom left is that patient with the big bump, and the bottom right on x-ray is with the bump gone. And that's all I have.
Thank you, Dr. Ramkumar. We're actually going to save questions for the very end, so we're going to have both surgeons up here at the same time. Dr. Ramadi, are you ready?
Okay. Hi, everybody. Thank you for coming. And also, I need to thank Memorial Hospital for basically organizing this event. So I'm going to talk about the shoulder and elbow stuff. Uh, shoulder is shoulder injury is very, very common. Shoulder pain is very common. As you can see here, in like a primary care setting, about 16% of the time people come for shoulder pain. So everybody, not everybody, about 70% of people actually will end up with the shoulder pain during their lifetime. And out of that, 70% of the time is due to rotator cuff issue. It's a very, very common problem. Oh, you cannot hear, sorry. One of the most common reason for shoulder and elbow pain is overuse, especially in younger people. So up to about maybe 70% of the time is due to overuse syndrome, and about 30% may be due to degenerative change, means that it's like wear and tear from aging, okay? So why is that? So this is the anatomy of the shoulder. As you can see here, we have the muscle around the shoulder. This is the front, and that's the back of the shoulder. We have rotator cuff muscles around the shoulder. There are 4 of them, 1 at the front, 1 at the top, and 2 at the back of the shoulder. If you look at the shoulder joint, we have a small socket and a huge ball on top of that, and the body is supposed to basically keep them together all the time. So shoulder joint has the most actually range of motion in any kind of joint in the body. It gives you huge range of motion. And the rotator cuff has a basically difficult job keeping them together. It's called the steering effect. No matter where your arm goes, the rotator cuff muscles needs to keep them together, keep them centered together. So that's a huge job. That's why the shoulder is prone to have more injury compared to the other joints. Okay, so if you look at the shoulder joint, so 2/3 of the motion comes from the shoulder joint by itself, and 1/3 of the motion is coming from your shoulder blade, okay? So if we want to basically separate the cause of the pain around the shoulder, we can go to 2 different big categories. One of them is going to be the problem inside your joint. It can be arthritis, for example. It can be labrum around the socket. It can be the ligaments around that. It can be frozen shoulder, infection, cancer, or anything like that, fracture. And then it can be tissue around the shoulder, like your rotator cuff, your biceps, like your tissue around the shoulder that can get inflamed, called bursitis. So when somebody comes to the office, the first thing we do is X-ray. X-ray gives us some limited information about the bones, about probably rotator cuff based on indirect, basically, information that we get from that one. And then if we need more information, we go to MRI. MRI gives us a lot of detail about the shoulder and rotator cuff. For example, on top one here, you can see there's a rotator cuff tear. And then this is another view of the MRI. So what you can see here, this is a normal muscle, okay? And then you can see here, this white area is fat, and the dark area is the muscle. So you can see the muscle is much, much smaller and does not fill the whole cavity here. So that's called atrophy. So when you have a rotator cuff tendon tear that is retracted over time, the muscle changes. It shrinks, it's called atrophy, and also some fat is going to replace inside the muscle. You can see the white area here, that's fat. So those changes, unfortunately, are irreversible. When it happens, we cannot reverse it. So if somebody has rotator cuff tendon tear that has been going on for a long time, and those kind of thing happens to the muscle, and even if we fix it, it's not reversible, and it's not going to go back to normal. So the reason I'm telling it to you is the timing for the repair is important. So basically, if somebody has a retracted tendon, the rotator cuff tendon that is retracted, then the timing of the surgery needs to be basically assessed by the surgeon and tell you if you can wait or not. So a lot of time in the shoulder, we have something called referred pain. The neck pain can go to the shoulder pain can go to the neck. Unfortunately, when you have a pain in your neck or your shoulder, you end up with the MRI of your shoulder or neck. And as we get older, we have lots of wear and tear in the body. If you get the MRI from your whole body, probably the radiologist is going to report like 200 different tears. So that doesn't mean that you need the operation for every single tear, okay? So we can have a tear in some part of the body that doesn't cause pain. So that's why it's important to correlate the MRI with the clinical finding. Otherwise, you can basically have shoulder pain, MRI shows rotator cuff tear, you have shoulder surgery, and then after 6 months of going through the surgery and rehab, you're still having pain because the pain was not from your shoulder, it was from the neck. So that's why it's important to pinpoint what's causing the pain. So this is not easy. Unfortunately, it's a very, very difficult job to do. We have something that can help us. The clinical exam, for example, can be very helpful to help us with the differential diagnosis. The other thing we do is we do selective injection. So we can inject your neck, we can inject your shoulder, and based on the response we get from that injection, we can help to pinpoint if the pain is coming from your neck or your shoulder, so you don't end up with the wrong operation. So, as I said, one of the most common cause of the pain in the shoulder is rotator cuff tendon tear, okay? So, as I said, most common reason for shoulder and elbow injury is overuse, okay? So, what does it mean? So, it's very important to know your body. So, if somebody's basically body is good to lift 50 pounds, somebody else's body is maybe not good even for 5 pounds. So people are different. Imagine like a submarine. So you go to a certain depth, and after that, the whole thing is going to crash. So basically, you need to know your body. So it goes to the amount of the force and the repetition of the force. You need to combine both of them, okay? So you need to know how much force you can put through that part of the body and how many times you can do that one to be safe. Maybe 5 pounds, 10 rep is good for somebody, and 50 pounds, 200 reps is good for another person. So if you go beyond that, you're going to basically end up with the injury. That's very, very common cause of the shoulder problem, okay? And the other common cause of the shoulder and elbow problem, any kind of body in orthopedics, is the fatigue. So you have been playing tennis for 2 hours, your body is fatigued, your muscles are basically tired. You keep playing, you are actually more likely to have injury. So that's very important. So you basically need to know. Unfortunately, there is no a fixed formula for everybody. I cannot tell, hey, you can do this much. That's your job. You have to gradually increase your level of activity to the point that your body is going to tell you, hey, this is your limit, you need to stop. If you go beyond that one before more preparation, you're going to end up with the injury. So this is a rotator cuff tear. And rotator cuff tear can be full thickness, means the whole tendon is torn, versus partial tear, means part of the tendon is torn. The partial thickness tear is very, very common, okay? This is an MRI study. This is the MRI study on asymptomatic patients, means the patient population had no shoulder pain. So imagine if you bring 100 people, they are between like 40 to 60 or 60 years old and above, okay? They never had shoulder pain. We get MRI from the shoulder. In this study, you can see that more than 50% of them already had a tear, okay? So it's a very, very common thing. It's basically wear and tear that happens over time due to degeneration as we get older. That's why I said that you may have a tear in your shoulder, you have MRI of your shoulder, and then you end up with the operation, and then you realize that the pain is not going away because it's coming from your neck, okay? Having MRI that shows tear does not mean necessarily that the pain is coming from that tear, okay? So when you have a rotator cuff tear, the treatment for that one initially is physical therapy, some medication like ibuprofen, and then also steroid injection can be very helpful. And eventually, if that doesn't work, you may end up with the operation, okay? So shoulder dislocation, I just want to put basically a few points in here regarding shoulder dislocation. When you are older, so you can see at the age of, for example, age of over 40, about 30% of the time, people can have rotator cuff tendon tear. When you are young and you have shoulder dislocation, The problem is going to be the recurrence of the dislocation. But when you are older, the recurrence of dislocation is not an issue. It's very, very rare to redislocate your shoulder again. Your shoulder gets stiff. But the main problem is you end up with a rotator cuff tear, and it's very common. You can see if you are 50 years old and 50 years and older, you can have 65% chance of rotator cuff tendon tear. Unfortunately, when you have dislocation, your shoulder is basically popped in an emergency department. You initially have pain. You go through the rehab. Nobody realizes that you have a tear because of the pain. It's very difficult to examine you. And then down the road, it can get missed and cause a problem. So that's why we need to pay attention. So if somebody has shoulder dislocation, we need to follow them properly down the road. And then when they recover from that kind of acute phase, we check and make sure that they don't have a rotator cuff tendon tear. And also you can see the nerve damage is about 25%. It's very, very high. Okay, so let's go to arthritis. Shoulder arthritis is very common. Right now, rheumatoid arthritis is not as common as before because of the new medication, but the primary osteoarthritis is still very, very common issue. So this is a classification for the erosion of the socket. So you can see this is the ball and this is the socket. This is the reason I put this one is to show you how long you can wait until you have the operation, because this is one of the most common questions I get from the patient in the office. They want to postpone the operation as much as possible. They want to wait, and that's very reasonable. I would do the same thing. So the question is how long we can wait. One of the basically criteria is how much erosion of the socket you have, okay? If you have too much erosion of the socket, this is the socket, almost no erosion. And then gradually you can get different erosion of the socket, and depend on the type of the erosion, we can tell you if you can wait or not, because it can basically change the type of the operation, and also it can change the outcome, it can change basically the success of the operation, it can change the longevity of the prosthesis after the operation. So it's very important to know which shoulder you have, and based on that we can tell you if you can wait or not and how long you can wait, okay? So the treatment for shoulder arthritis is activity modification, medication, steroid injection, physical therapy, okay? So physical therapy is a little bit tricky here, so remember that. This is one of the biggest mistakes I see. Patient come to the office, I tell them physical therapy, they say, oh, I just did physical therapy, it made me worse, I hate them, my shoulder pain is worse right now. The problem is they're doing the wrong physical therapy, okay? So this is the deal. When you have arthritis in your shoulder, that means that you have two surfaces that are not smooth anymore. They don't have a cartilage. Imagine that two pieces of sandpaper and the two rough surface, and you are trying to push them together. When you start doing some strengthening of your body, so what happens is the muscle around the shoulder contracts, and then it squeezes the joint together. It's called the joint reaction force. Basically, it compresses them together. So imagine you have 10 pounds weight on your arm, and you're trying to move to strengthening. Your two surfaces, the two sandpaper, are basically rubbing on each other. It's a bad problem. So you have to do a different kind of strengthening. In this kind of situation, we ask for isometric strengthening. Isometric strengthening means that you are putting force through your shoulder, but your arm is not moving. Your muscle around the shoulder is getting a strengthening, is basically contracting, but it's not moving. So you don't basically grind the bone on bone anymore. So that can be helpful. So again, you need to do the right physical therapy, otherwise you're going to end up with more pain and more erosion of the bone. Eventually, if the non-operative management doesn't work, the next option is operation. With the operation, you can have shoulder replacement. Shoulder replacement actually is not a difficult operation, is a very easy operation, is a very short operation. Recovery is not too bad. So the operation is done through incision in front of the shoulder, and then we replace the shoulder. Right now, the process has evolved a lot, actually, compared to like 10 years ago. We have newer prostheses. Right now, for example, we have stemless. So this is the new version that does not have any stem. It preserves the bone. The revision operation is much easier. The fracture rate is less. And overall, the complication rate is much, much less. So Overall, better process right. It gives you a good range of motion. It gives you good pain relief. There is some limitation associated with that, of course, but overall, it has much, much better outcome compared to whatever we had before. This is the anatomic shoulder replacement, means that the whole process looks like your shoulder. And then we have something called reverse shoulder arthroplasty. If you have arthritis in your shoulder and you have rotator cuff tendon tear, the regular shoulder arthroplasty does not work. So they designed something called reverse, and it's called reverse because the position of the ball and socket are reversed. So basically, the ball, instead of going on the arm bone, is going on the socket side, and the socket goes to the other side. And this way, we can manage the arthritis in the patient with the rotator cuff tendon tear. Reverse shoulder arthroplasty, the recovery is very, very fast. The operation is much quicker, actually, than the anatomic one. The reverse shoulder arthroplasty, the recovery is very short. So basically, the patient can go back and start the daily activity in about 2 to 4 weeks. Very, very quick recovery. Good range of motion, good pain relief, and good success rate. So fracture. So proximal humerus fracture is one of the basically most common fracture in human body. So it's a very, very common fracture after a fall. And I can tell you 70% of the time it does not need the operation. So about 30% of the patient needs the operation. The treatment for this one is basically trying to minimize the pain and maximize the function. We are not looking for the gorgeous X-ray. It does not need to basically heal in the proper position. We can accept loss of displacement in the shoulder fracture. The fracture can heal in a really displaced position and the patient does fine. Okay, so basically we have lots of room for the shoulder fracture not to operate, and that's why 70% of the time the patient does not need the operation. And then if there is basically some criteria, some indication, then we fix it with the plate and screws or other stuff. Frozen shoulder, very, very common problem. And I can tell you what's happening is the patient comes, they have painful shoulder, and the shoulder gradually becomes stiff. So we don't know why it happens. Still, we have no clue, but we know that there's some situation that makes the patient prone to this. If the patient has basically diabetes, any kind of endocrine disease, if they have any kind of heart attack, any surgery on this side, like mastectomy, female, and some other diseases can basically put the patient at risk of this problem. So the patient ends up with the stiff shoulder. The patient's shoulder is stiff, is painful, and then they go through 3 different phases, and eventually it becomes loose again. The shoulder gets the range of motion back in about 70% of the time. Unfortunately, 30% of the patients end up with the surgery because whatever we do with the physical therapy and home exercise and injection doesn't work. So if it doesn't work, there are 2 different treatments for that one. One of them is manipulation under anesthesia. Basically, we put the patient to sleep and we do something the physical therapy is trying to do in the office. It's just the difference is the patient sleep, they don't feel any pain, so we can basically push it beyond the limit. And then what happens is it breaks the scar tissue. The other option is shoulder arthroscopy and capsule release, and that's kind of more controlled release of the capsule and the scar tissue to release the shoulder. So let's talk about the elbow. Lateral epicondylitis, tennis elbow, very, very common issue. So again, most of the time due to overuse. So what is lateral epicondylitis? So what's happening is there is a group of the muscle that attach to the side of the elbow, and that comes to the wrist, and it's responsible for the extension, means basically raising the wrist this way. And repetitive motion, repetitive use, and also heavy kind of lifting and heavy motion, use of the arm can cause this. So what's happening is, this is the normal fibers of the tendon here, and then it becomes something called tendinosis. The tendon changes, and eventually it can cause a tear in that area, and that called lateral epicondylitis. The same thing on the medial side can happen. It's called golfer's elbow. So the treatment for that one is rest, activity modification, ibuprofen. We can use some bracing, injection, and eventually, if it doesn't work, operation. Before the operation, we do the MRI because sometimes it can be associated with something else. For example, this is called plica. It's a fold of soft tissue, synovium, that gets inside the joint that causes pain and inflammation. And at the time of the operation, we basically clean up that area as well. So elbow arthritis. Elbow arthritis is not as common because rheumatoid arthritis is treated very well right now. Right now, most of the time we see that one is post-traumatic, means after trauma. Somebody has elbow fracture, and then due to that elbow fracture, they can get arthritis. And then if arthritis is in the initial phase, it causes something called impingement pain. That means that we have pain at the end of the range of motion, not through the range of motion. With that kind of situation, it can be easily treated with elbow arthroscopy. We put the camera inside the elbow, we clean up all of those extra bone, and the same thing with the hip. Basically, it prevents the impingement and improves the pain. But if it becomes advanced, unfortunately, the patient is going to need elbow replacement. So, for the shoulder replacement, we had the robot for the hip and knee replacement, and we did not have that one for shoulder. We have been using some basically navigation systems, some pre-op planning with the computers. We had some patient-specific guides, but we did not have any robot. So recently, there was a robot that has been used for the knee and hip. It has been modified to be used for the shoulder. It got the FDA approval, and right now we are in the basically process of acquiring that in Memorial Hospital and using it hopefully in a month. So what ROSA does is basically it helps you to create a precise and accurate placement of the prosthesis, the implants. Something we have been trying to do it with other means, but right now the robot can help us to do it much easier. It's a real-time, basically intraoperatively, it's interactive, it can help you to adjust it if you want to, and also it basically adapted to the patient's anatomy, and it basically personalized based on the patients, based on your pre-op planning, and that's why you can put the implant in a very, very precise manner. So this is ROSA. Again, it's the same thing, but it's not as cute as the other one. So it has some arm like this. So we do the pre-op planning, and then ROSA is going to basically do exactly the same thing during the operation. So we put some sensor on the bone that is going to help ROSA to understand the anatomy of the patient. So basically, we are registering that one with the computer right now. And then that's the sensor, and then the robot comes and does all of the jobs. And so basically, it's going to be very helpful for precise planning and putting the implant in the right position, especially in people with difficult anatomy. For example, erosion of the bone can be very, very helpful.
Alrighty, can we get a round of applause for both of our surgeons, please? And now everyone's favorite time, questions. Okay, we have one. So what I'm gonna do is I'm gonna bring the mic over to you. We're gonna turn it on and then try and hope the static doesn't go. Oh.
Thank you for your time. Is there an individual group or program that we can go to teach us preventative injuries to various shoulder, hip, knee, and the same group, if you do get a problem, to take you through the recovery process? That was question one. Then second would be, how do I know if it's something that could be physical therapy through or surgery required?
I am not aware of any group can do it, to be honest with you. I don't know if you are. The best thing to do is the physical therapist can be very helpful. So the physical therapy can work with you and tell you, you know, if you're, for example, your shoulder, that part of the body has good strength, good basically range of motion. Do you have any problem? They can help you with, if you are a tennis player, if you are a golfer or whatever, they can help you to adjust that one. If you have a trainer, for example, they can help you with your technique, with the type of the basic equipment you're using. But otherwise, I have not seen any kind of group that can do it.
Is there something that is it a situation where we would come to you first? Because you mentioned some of the physical therapy, they're doing the wrong movements.
Correct.
So you go to you, then you analyze that and send it to them, or?
That can be helpful, yes. Depends on the situation, to be honest with you. If you have a problem, depends on that. So there's no fixed physical therapy for everything, okay? So there's different physical therapy for even for the shoulder. You know, if you have a frozen shoulder, you're going to get a different physical therapy from rotator cuff, from instability. So it's different, yes. It can be very helpful.
Thank you.
So the way I understand your question is, you know, how can I not end up on the operating room table? That's like part one. That's what everyone wants to know, right? To avoid us. I get it. I would want to avoid me too. The second question that I hear you asking is, how do I know when I'm burning a bridge, right? Okay, so to avoid ending up on the operating room table and to enjoy living your life and doing all the things that you know that are in your control, the first thing you can do is make sure that you're of a normal weight and you control your weight. So that's basics. That's a common cornerstone of a lot of things where complications can arise should you ever need a surgery. So control your weight. That's what you can control. Secondly is control the way you live. If you smoke, regardless of shoulder, elbow, hip, or knee surgery, I'm not going to electively or choose to operate on anyone who smokes. You automatically double your risk profile, okay? And you decrease the chance of you healing well. The third thing you can keep in your control is if you have diabetes, which sometimes you can control that, sometimes you can't. But if you have the type that you can control diabetes, that needs to be your focus because it leads to a whole host of complications, and every single research paper says obesity, diabetes, smoking, 3 modifiable risk factors that people can control. So that's 3 ways that, within reason, you can help avoid people like us. So the second question that you asked was basically, how do I know when it's gone too far? I'll tell you just as a rule of thumb from training and so forth, usually if you have a nagging problem at the magical 3-month mark, that's when things become more serious. We typically don't jump to something unless it's been at least 3 months of trying sometime. That's a magical window when we know something's not right. So if someone comes to me with arthritis and 1 month of knee pain, I will automatically say, you definitely need to stay away from me because there's a good chance that this gets better. We just don't have enough information or data points to know which way this is going to go. And 3 months is a decent data point to do that. So I hope that kind of answered that. Vicki? Oh, she's got it right there.
Okay. My question refers to how do we educate the primary care providers to really listen, you know, because like in my case, I've already had 3 joint replacement. And Dr. Ram Kumar is my favorite orthopedic surgeon. He did both of my knees, and I'm perfectly doing well now. But for those who are not able to really express and articulate themselves when they go to their primary care provider and be able to say, my shoulder hurts, my hip hurts. How do we can we expect them to listen and really examine you and not just give you lip service? Because like what you're saying, an early referral to an orthopedic specialist is probably critical.
So, okay. I'll respond to that by first saying the general doctors, the primary care doctors, they have a lot on their plate. Their job is to triage and elevate when things they know from when they learned and when they trained things were problematic. I guarantee you if I gave my exact same talk to this entire room of primary care doctors, their mind would be blown. My mom is a primary care doctor, and she had no idea that hip impingement was a thing. She thought thigh pain, hip pain was just something you live with. And my sister underwent this surgery 2 months ago. And she felt horrible because she felt like she hadn't failed her daughter. And only until I was done training and educating and learning this, that my own sister has this huge issue that can easily be fixed before she has arthritis. Now she's back to doing all the things that she loves. So it's incumbent on us to understand that these primary care doctors, they're dealing with 7 different problems someone could have. And so and some of it's in their control, some of it's not. Lip service, I kind of take a little, they're doing the best they can is my first answer. The second thing is a lot of it's HMO insurance systems that just take a long time. Vicki, I know you know most because that's your background and your training, and you understand that's a hard thing to navigate. But the system is not in favor of seeing experts, and that's just a plain fact, and why it's beneficial to have a PPO, and that's just plain as day, unfortunately, the truth for a lot of this. I don't know if you want to add more.
So the only thing I can add is basically most of the insurances want to make sure you have burned all of the bridges and you have done everything that's possible before you go to a specialist. So if you go to your primary care and you have shoulder pain, for example, just be precise. So tell them, hey, I have this shoulder pain, started 3 months ago. I have done whatever I could to stop the pain. It's getting worse. I tried this medication. I tried this exercise. I stopped doing this activity, and the pain doesn't stop. So then probably it's the right time to see the specialist. I don't think they're going to say no to that.
Hello. Sorry, I had the mic. Sorry. Just quickly, I don't know if this is a question or comment. For people who have joint issues, back pain, I mean, maybe, I don't know, MemorialCare maybe have maybe sports medicine or physical medicine rehab doctor. They also can, I think they can be also assistants. I mean, maybe the orthopedic.
Josh Snodgrass, he was supposed to speak here today. He's amazing and does a great job of doing all that.
Yeah, so I mean, I think, I think Dr. Ramkumar is totally correct that, primary care had to take care of a lot of issues, but, think about maybe go to the physical medicine rehab or sports medicine specialist. I think they can maybe help you to assist on some of those things.
Oh, this is a hot spot in the front.
Yes, so I think I was hearing if you have I don't know, hip soreness or whatever. I've been kind of dealing with something for a couple months, and I'm trying to figure out if I'm just doing things wrong, walking on it wrong or whatever. But if you have a PPO, you should try to get that looked at right away, or?
That's not my takeaway.
Okay.
My takeaway was certain insurances, if it's beyond 3 months and it's been lingering and it hasn't gotten better with the things that you've been doing, that's typically when it's time to see someone. I was just saying to get early access, because we have a very stretched out thin system, PPO insurances tend to offer you the ability to accelerate the process that Vicki was talking about, where things can be very difficult and it's easy to get lost in the bustle of how difficult it is navigating the healthcare.
Okay, so I should see my primary care and try all the other things first.
Yes, one more thing. Orthopedic pain mostly is biomechanical pain. That means that when you're doing something, it happens. So if you're experiencing rest pain, okay, so you're not doing anything and you are having excruciating pain, you have a severe pain, okay, so that's a different story. You do not need to wait 3 months. So that's something you should see your physician probably as soon as possible. So that's a different story. So again, there's some pain, mechanical pain, 3 months is reasonable, even shorter, but I won't wait even that long. But again, if there is non-mechanical pain, probably should not wait that long.
Okay, and then I just started a gym membership. I should just take it easy because I'm 65, so I should be careful.
So again, everything is the same thing. So start slow and start gradually. Start with the smaller weight, the smaller force, the smaller repetition, and then gradually go up. And then at some point, your body is going to tell you to stop.
Okay.
Okay, I'm going to chime in really quickly. We have a question from our virtual attendees. One of the questions is, can you talk about the downstream events of arthritis and its relation to balance disorders and the need for PT in the long term? I think this is supposed to go to Dr. Ram Kumar.
So if I understand the question, what's the risk of having arthritis and affecting balance disorders?
It's, yeah, in relation to balance disorders.
If you have severe arthritis, it becomes difficult and it's hard to predict when it's going to bother you, especially depending on whether it's a hip or knee issue. It can cause locking, and that can be very difficult to negotiate your balance and feel like when it's time. So, I mean, the short answer is being in pain can cause you to feel like you don't have a sense of control of your body and therefore lose balance.
Hi, I have a question. In hip replacement and shoulder replacement, what materials are being used for that?
So for the shoulder, it's basically an alloy. It's a cobalt, chrome, and titanium, and there is a plastic piece also involved with that.
I have a question. On August 25th, my husband have cervical spine surgery, okay, performed by Dr. Brandon Ortega, the orthopedic in Long Beach, okay, and he's in the back of the neck here, and but he's seem like the wound is healing, but his right hand is cannot move. Before surgery, he don't have that kind of problem, but this after surgery, that is more than 6 weeks ago, but now he's the right hand he cannot move up. Can you help?
So there's so many things that can happen. So it can be from the shoulder, it can be from the neck. For example, let me give you the shoulder part. So you can have shoulder problem due to positioning during the operation, for example. You can have shoulder problem because of the pain after the operation, not moving the shoulder. You can get frozen shoulder. You may have a rotator cuff tear that got aggravated during the operation or after the operation. It can be from the neck. Sometimes the nerve damage, nerve inflammation, or something else can happen. So basically, that needs to be seen by your physician, and they can tell you what's happening.
I can let Dr. Ortega know, but C5 palsy is a known complication after neck surgery, and usually it takes up to 3 months to a year to get better, but I'll let him talk to you about that.
This is for Dr. Ahmadi. You mentioned that before the surgery, taking something like ibuprofen and things like that, or cortisone shots. Well, what do you think about those patches which are available, iono patch or things like that? Are they useful?
It can be useful. I have some patients that they're using the patches. They use lidocaine patches. They use diclofenac and other patches, and that can be helpful, yes.
So it's something in between taking a cortisone?
You can use them, yes.
Thank you.
Yes, I wanted to ask a couple, 2 or 3 questions. Try not to take too long. When you do a replacement, whether it's a hip or elbow or shoulder, what keeps you said there's a problem with the muscles keeping that together. Right after the replacement, what happens to that muscle? Do you need to go through therapy or whatever in order to, when it's healing, or what?
So when we do the shoulder replacement, we have 2 kinds of shoulder replacement. There's anatomic shoulder replacement. During the anatomic shoulder replacement, we take the front part of the rotator cuff tendon off the bone and we reattach it again. That's why the patient is in a sling for 6 weeks for that to heal, and then they go through the recovery to strengthen the muscle. And about 5 to 6 months, the muscle around the shoulder goes back to normal.
What do you think about stem cell therapy?
As up to this point, I can show you the paper. I can bring you the paper. None of the stem cell therapy works. So the amount of the stem cell in all of the basically commercial one is not enough. There is no evidence that that works. So it's just waste of your mind.
I would say, so for arthritis, I agree completely, but for certain tendon injuries, PRP, certain stem cells work wonders. So, yep, so for x-rays, we have our own x-ray site on site. MRI and CT, we rely on outside contracted places, but x-rays are the workhorse of everything I do, so, or the majority, so it's more than often good.
In my group, we have both MRI and X-ray and physical therapy as well. We have physical therapy in my group.
Same.
So basically, we need to examine your shoulder. So we need to see if you have basically full passive range of motion of the shoulder or not. If your shoulder is coming up to here, and then when I try to push it, it doesn't go further up, it's probably a frozen shoulder. It can be arthritis. There are several reasons for it, most of the time frozen shoulder. If your passive motion is good, your active motion is not good, probably is going to be a rotator cuff issue. But again, without examining properly an x-ray, we cannot tell you.
So the question was, is the physical therapy center have licensed therapists? All of ours do.
So she's asking that she has pain in the right shoulder because of the rotator cuff tendon tear, and then also pain at the left side of the neck, and pain with the range of motion of the neck. So those are two different issues. So for your neck, probably you need to see a spine surgeon. I don't know if you had x-ray and how long the pain has been going on. They have done MRI, so it depends on the situation. For your shoulder, again, I don't know if that tear was based on MRI or just physical exam. That diagnosis was, they did the MRI. So it depends on the size of the tear, depends on which muscle, which tendon is torn, depends on how much of the tendon is torn. It's a very complex thing to make a decision. So if you have a partial tear, it's kind of different from a big retracted tear. The treatment is different. So again, it all depends on the MRI finding. And then we start conservative management, means physical therapy, injection, and if it doesn't work, operation eventually. And the type of the operation, again, will depend on the type of the tear you have. For the neck, they can do the same thing. They can do physical therapy, they can do injection. And have you had injection for your neck? Yeah, the injection can be helpful too. So talk to your spine surgeon. They can help you with that.
The question is, what's my view on yoga? I think yoga is great. You should only do activities that don't cause you pain. I think people know the difference between soreness after a good workout versus pain while you're doing the workout. And so I have nothing negative to say about yoga.
So with physical, not really. But physical therapy is very, very unlikely to do more damage unless the physical therapist is too aggressive and they're doing something really wrong. So, no, I know. But, what physical therapy can basically do wrong is they may aggravate your pain. But they're not going to do, honestly, they need to do something really drastic to make your shoulder worse or your elbow or something really worse. So they may increase the pain, but again, to increase the size of your tear or do some damage to your shoulder, they need to do something really crazy.
So can we give one more round of applause for our surgeons? So on behalf of Long Beach Medical Center MemorialCare, we thank all of you for being here. We are specifically here to answer your questions. So I know there was a question, are you through MemorialCare? They are not employed physicians, however, they are contracted to work at our hospitals, so they both have private practices where they work at, different practices, so if you're interested in where their offices are, we have information on them, and they are going to be around for maybe 5 more minutes for some questions one-on-one, and then we just want to thank you again. So thanks, have a good night.